If there are no more comments, we'll move on with Anand's presentation. Thank you so much, everybody. Anand, are you able to share the? Yeah, you're muted, still muted.
Okay. So, are you able to see my?
Yes, we can see a desktop, which
Okay.
seems to be much cleaner than mine.
Yeah. So I'm going to present to you a fairly challenging case of FEVR detachment. So our patient was a 17-year-old female with pre-op vision finger counts, and one-eyed patient with a total detachment, as with the intimating picture, as you can see here. So in these kind of cases, I prefer to put in a encircling band, and I'm suturing and securing a 240 silicone band, 2.5 in width, and after which I proceed with a 3-port 23 gauge vitrectomy here in this case. And as you can see, it's pretty tough adherence of the vitreous to the periphery and posterior pole, and you can see that glistening luster is because of these crystals coming out from the FEVR. It's almost crystalline, and now with the 10,000K cutter, which has the advantage of having the bevel there, getting into these tight spaces, creating that rent in the posterior hyaloid, and then undercutting, and then as you can see, it's just detaching and then going around that neovascular tuft, and you can see a multiple neovascular tufts around, and you can see that horseshoe tear with a rolled up edge under this almost crystalline vitreous. And then I'm going parallelly so as to reduce the tractional tug on the neovascular nets. And now with the unimanual dissection of the vitreous being attempted, first with the scissors and then the forceps, I realize it's pretty futile, and then move over, quickly switch over to bimanual, put in the chandelier, and then elevating the vitreous in the classic manner with the left hand with the forceps and the right with the curved scissors. And you can see and appreciate perhaps now there are a lot of subretinal exudation and multiple neovascular tufts around, and kind of do it piecemeal, and it took me about a good 10 to 15 minutes to get most of that away. It's almost like a plateau adherence, and ultimately it kind of became a little more mobile in the posterior pole. You can see the PFCL being dropped in and rolled it up to the edge of that HST, and then now proceeding with the peripheral base dissection. You can see it's pretty tough. Now you can see that I'm extending, trying to excise the stiff temporal edge, first with saline, and now, as you can appreciate, with under air. I kind of prefer, and you doing this kind of peripheral relaxing retinectomy under air for three reasons. One, you can aspirate, pull it up, and you can you can assess and determine how much of retinectomy you need to do. You can continuously assess. B, it gives you a panoramic view. And C, in cases like this where a lot of hemorrhaging is anticipated, it clears up the wispy hemorrhage immediately, and you can see better. So right now I'm continuing with that relaxing retinectomy, and you can see that stiff edge temporally, and you can perhaps now appreciate the shallow contour of the buccal showing up, and you can see that's tenting up. It's going to tent up. That, yeah, right now it's tenting up, and you can see it's going to scroll up also. And I continue in this cycle of aspirating, assessing, and cutting. So I'm continuing with that radial retinectomy, and now going and taking that anterior flap, and to the point that the retina all around, to my satisfaction, is settling down on the RP choroid. And you can see how thick that temporal retina is. This because of the organized exudate of PVR, causing that retina to be that stiff. And I was actually quite surprised that I was able to do that almost the entire thing with FAX at 40. And now continuing and doing a broad endolaser 360 degrees, multiple neovascular nets were there all around, so I had to do that 360. And now proceeding with fluid air exchange, and you can see it's fairly well settled now, and just removing the last residual amounts of the bleed, and taking out that PFCL in toto, and then dropping in the silicone oil finally. And you can now appreciate the dragged vessels and conjunctival closure, and post-op day 1 acuity improved to B 636, and finally you can see a good outcome with the comparative pictures. So that was the case. I'll stop with that. Thank you.
Beautiful, beautiful case. I love the under ear vitrectomy and
yeah.
retinectomy. That is something.
I think that was
yeah,
a
which-
fantastic point.
Yeah.
yeah, that is true. Any comments? Any thoughts?
I have a quick question. That was
Yeah.
a very beautifully done case. When you do it under air, do you have any concern if you have a lot of tenting of air getting subretinally?
Yeah, so the thing is, you need to be at the most peripheral edge. So it's ideal if you, as you get in air there and you keep it right at that anterior edge. Don't go immediately down to the posterior. So you saw, I anticipated that the edge needs the retinectomy. So I just go up to that point and keep cutting underneath. If you go posteriorly, that is when you can have the air tenting under. But then if you do get that, it also tells you the fact that that particular retina needs to go. So that is why that's what I said. It's a cycle of aspirate, assess, and cut.
Yeah, and I have done in a couple of cases, and I particularly feel that because I switched myself from Alcon to Wash and Lam just to experience newer things. But the biblade retractor, which they have, also helps a lot. And considering the beveled edge, what you are explaining, certainly helps in doing this under ear work.
Yeah.
That is very useful.
And just note about the bevel, I think they keep talking about the 10,000 cuts, but for me, what is greater bang for buck is the bevel. It really gets you into those very small, tight spaces, and you can actually do, especially in these kind of cases where there's a lot of adherent vitreous from posterior to periphery, it gets you into those small spaces and allows you to do a lot of unimanual vitrectomy to tackle these membranes.
True. We have 3 hands standing. Mahesh, sir?
Yeah. Please.
It's a very, very difficult cases and wonderfully managed, Dr. Anand.
Thank you.
One thing I was wondering was like when the HST was small enough, what I would have done is probably slipped a buckle there. So he had put an encircling band, a solid silicon, a very broad silicon, a 279 or 270, 280. So that way we can avoid this extensive retinectomy. Because like the vitreoretinal anatomy is very, very difficult in these patients and well managed, but that's the only different I would have done.
Sure. It's just that, I wanted a band there. I wanted some amount of support because actually I failed to mention, one good question that can come up is why do a retinectomy when you have a band? But the thing is, in several other areas, there was just a little amount of peripheral PVR and exudation which nicely sat on that shallow band.
I would have put a band. I would have put a solid silicon.
No, I understand. You would put a big,
under the HST,
a big. So I've kind of migrated away from that, especially when I have to do a vitrectomy alongside. So I've kind of pushed away from that. So I kind of prefer a localized retinectomy. Yeah.
Good.
Actually, all of us have become lazy in putting a buckle. Once you are already doing a vitrectomy, you become lazy in putting that buckle.
Yeah. So
Dr.
cosmetically, it's a kind of a better thing than having a huge heavy buckle out there.
Yeah.
If I were to put a huge heavy buckle, I would kind of do it in cases. I do that a lot. In fact, yesterday I did this particular case. I did exactly last Saturday, so I don't have a long follow-up. But I do that. I wouldn't want to prolong it and go again with a vitrectomy. So that's the thing. Yeah.
Let's get some comments from Parveen.
Dr. Ajay and Dr. Parveen.
Yeah. Anand, tough case. I agree. These are difficult cases. You would have spent 3-4 hours in the OR on Saturday. But I also do this vitrectomy under gas very often, especially when you know that you are going to do in a children where there's a lot of gel vitreous you end up leaving in the periphery, and it is very difficult to peel and cause a PVD. But the trick here when doing the under air is you have to have a suboptimal fill with air. You cannot have a too much of complete fill. Then the vitreous gets plastered onto the retina and the periphery, and you cannot peel it off. So if it is just below the edge of the vitreous that you are going to cut, so that keeps the vitreous afloat, and that helps you to remove it very safely. So this is some technique which I have also learned, like you have in the last few years, that it really works in pediatric eyes where you cannot induce PVD. And I agree with Dr. MPS, buckle would have made your life a little easier, if not too much.
Thank you. Ajay, sir?
Yeah, so Anand, beautifully done, very good case. This is just an extension of what Alexandra said and what Dr. Praveen thought out. If you increase the pressure, have you ever had a situation where your relaxing retinotomy extends uncontrolled?
Not really, because
if you have not relieved all the traction, Because I've had in one of the cases, and then I'm really scared about doing a relaxing retinotomy under air.
Yeah, actually, that kind of happens when perhaps if it was a very high myope and you have a lot of breaks, definitive breaks, and a lot of thin areas all around, then yes, it can happen. I think if I'm not mistaken, Anirudh Maiti showed a case where under air he had multiple retinectomies, spontaneous rectomies. Yeah, I think he did in our retinol session or Joe's session. So that can happen. But this, as you saw, that particular edge was so stiff. You had to actually, I had to, you probably saw me, with a cutter, I was making multiple passes that, trying to get that to cut. It was actually so thick. So here it was just the opposite. Instead of breaking, it was just tenting up. So that kind of told me, and I just needed to do a slicing kind of circumferential retina.
Retina was playing your tune.
Yeah.
Great.
Again,
All right.
because of the partial FG, I think that it did not really rip it apart. If you do too much
Correct.
of it, then
Correct.
it will just open it up.
Also, you need to do it at just the right amount of pressure. You should not do it at 60.
Yes.
That is also another factor. So as I pointed out, that the entire surgery was done at 40. So I didn't go high. So if you go high, yes, you can. And if you come posterior, it can lift up that whole thing. And if there were weak areas, that might have broken through.
If you carefully look at the video, also the instrument, the cutter probe, you can see the level of the fluid and the air.
Correct.
So there is saline behind, so which is avoiding the complete rip off